and welcome to the last but not least important session of the day, which is an occasion for the Pontifical Academy for Life to present the white paper. And then we have two discussants who will comment on the paper, and hopefully we can all, after that, we can all contribute. And as John said earlier, when we finish that session, we will immediately move into the concluding one, which is listed in the program, and talk about potential next steps and so on, and hopefully also solicit last comments and suggestions from you. The presentation of the white paper will be by Dr. Nunziata, is that the right way? Comoretto. Dr. Comoretto is an official researcher at the Pontifical Academy for Life in Vatican City since 2011. Previously, she was a researcher in clinical ethics and assistant professor of bioethics at the Pontifical Gemelli School of Medicine, Catholic University of Sacred Heart in Rome, and the clinical ethics consultant at the Pontifical Gemelli Hospital in Rome. She has been a visiting scholar at the Center for Clinical Bioethics at Georgetown University in DC. Currently, she is a visiting researcher at the Atlantis Program, Human Dignity, Advanced Illness, and Palliative Care at the University of Navarra in Spain. Dr. Comoretto has published on a wide range of topics, including the anthropological and ethical foundations of clinical ethics, and we've had many references over the last 2 days to both aspects of the importance of both aspects of this field. She's also published on the ethics of end-of-life care and palliative care and the physician-patient relationship. The two discussants today are Dr. Khalid Al-Ali and Dr. Azza Hassan. Dr. Khalid Abdullah Al-Ali is the Director of Higher Education Institutions Affairs in the Ministry of Education and Higher Education in Qatar. He has served previously as the Associate Vice President for Faculty Affairs at Qatar University. He has a PhD in human genetics and has several publications in the fields of cytogenetics, is that the way to say it? Cytogenetics and bioethics. Most recently, he co-authored a book titled Islamic Bioethics, Current Issues and Challenges. He was the chairperson and a member of the World Commission on the Ethics of Science, Knowledge and Technology, COMEST, and in UNESCO, and the Arab Committee for Science and Biotechnology Ethics. He chairs Qatar's Biomedical Research Institute, the IRB, and is a member of IRB at Weill Cornell University and at Qatar University and Qatar Biobank. Dr. Ali is a member of the Board of Directors for the Qatar Cancer Society, a member of the Board of Trustees for the North Atlantic College, University of Calgary, and Arabian Gulf University of Bahrain. Our second discussant is Dr. Azza Adil Ibrahim Hassan. Dr. Hassan completed her medical education in 1986 from Alexandria University in Egypt. She received her master and doctorate degrees in clinical oncology. She was certified by American Board of Hospice and Palliative Medicine in 2003. Currently, she is program director and the head of the supportive and palliative care section of the National Center for Cancer Care and Research at Hamad Hospital Medical Corporation in Doha, Qatar. Dr. Hassan is also assistant professor at the Medical Research Institute in Alexandria University. She is as well assistant professor of clinical medicine at Weill Cornell Medical College in Doha. She has several publications in the field of clinical oncology and palliative medicine and has been at the forefront of advocacy and research on biomedical ethics and palliative care. She is an active member of the Supportive and Palliative Care Working Group of the European Society for Medical Oncology, the Middle East Cancer Consortium, and the Multinational Association of Supportive Care in Cancer.
In this presentation, I will briefly introduce the Pontifical Academy for Life. Then I will describe briefly the PalLife project and present a white paper for global palliative care advocacy promoted by this project. The Pontifical Academy for Life is an academic institution of the Holy See in Vatican, established by John Paul II in 1994. The Pontifical Academy for Life exists for the promotion and defense of the value of human life and of the dignity of the person. The Academy has the specific responsibility to study the problems connected with the promotion and defense of human life from an interdisciplinary perspective, to foster a culture of life through suitable initiatives and always in full respect of the magisterium of the Church, to inform the authorities of the Church, mass media, and the civil community in general about the most relevant results of its study and research. As recently recommended by Pope Francis in the letter Humana Communities, that is in your folder, our work should aim at promoting a humanism of fraternity and solidarity between individuals and peoples. In 2017, the Pontifical Academy for Life has launched the PalLife project to advise on how the Catholic Church could assist in continued palliative care development at the global level. Indeed, caring for the sick people has been part of the missionary activity of the Catholic Church since its inception. For example, the Catechism of the Catholic Church refers to palliative care as a special form of disinterested charity. As such, it should be encouraged. The magisterium of the Church has intervened several other times in recent years to emphasize the dignity and the preciousness of each human being, even of those who are afflicted with serious or terminal illnesses. The Pontifical Academy for Life has been especially committed to palliative care advocacy. Recently, it dedicated 2 annual General Assemblies to the topic addressing the challenge of aging and disability in 2014 and that of assisting the elderly and palliative care in 2015. In the 2015 General Assembly, Pope Francis gave us the key message for the launch of the PalLife project. He shared meaningful words that have already been recalled during these days, but I think that we can read them again as they are so inspiring. Palliative care is an expression of the truly human attitude of taking care of one another, especially of those who suffer. I encourage professionals and students to specialize in this type of assistance, which is not less valuable for the fact that it is not life-saving. Palliative care accomplishes something equally important. It values the person. Following the Holy Father's words, the aim of the PalLife project is to stimulate the social and cultural attention on the reality of palliative care and to promote, at different levels, the dialogue and cooperation between the various stakeholders in the realization of concrete projects of palliative care. Global palliative care advocacy will be reached through the promotion of greater sensitivity in ecclesial realities toward the need to develop good palliative care in different areas of the world. Increased attention by non-ecclesial institutions, NGOs, and associations working with similar aim. acting as an interlocutor for academic and scientific institutions in the promotion of palliative care and coordinating with other religions on the diffusion and development of palliative care in the world. The PalLife project is based on an advisory group that has been created to inform the Pontifical Academy for Life, offer guidance and advice in promoting and advancing palliative care globally. The expert group was selected considering and balancing diverse geographical regions and professional backgrounds, and all these experts are also very well-known advocates for palliative care, and they have also different spiritual and religious background. Here you can read the names and the countries represented. For example, Sami Al-Serafi from Egypt, Eduardo Bruera from United States, Carlos Centeno from Europe, Liliana de Lima representing Latin America, Emmanuel Eurica from Uganda, Daniela Mozoio from Romania representing East Europe, Katrin Pectus representing international organization, Christina Puchalski, that is a leader in spirituality in medicine, Raja Gopal representing India, Thomas Sitt representing the Christianity Protestant, Young coming from South of Korea, Mary Calloway on behalf of associations, volunteers, and Katie Foley as a pioneer of palliative care. The group met the first time in April 2017 in Rome. In that meeting, the group decided a basic strategy of the project and two main actions for the next future. First, to write a white paper for global palliative care advocacy. Secondly, the group recommended the Pontifical Academy for Life to celebrate an international meeting to launch the PalLife project. The meeting took place in February 2018 in Rome. A report with the result of this first meeting has been published in an academic journal. The report submitted as a letter was accepted immediately by the editor without any change required. We perceived this rapid acceptance as a welcoming of the project launched by the Vatican, by the international scientific community. As recommended by the group, we immediately started a process to elaborate a white paper. Now the white paper represents a position statement of the Pontifical Academy for Life regarding palliative care. It is intended to be used for advocacy with local governments, healthcare organizations, leaders on the ground, and faith-based communities. To build the white paper, a process was developed to generate consensus among 13 palliative care experts on key recommendations for major stakeholders group, including ranking both recommendations and stakeholders group by importance, as well as providing suggestions for the implementation. Several versions of the white paper have been planned since the beginning. Summarizing, 13 stakeholders group and 43 recommendations result from the first round of the process, and of those, 13 recommendations were chosen as the most important, one for each stakeholder group. This is the first version of the white paper that has been presented at the International Congress in Rome, and it contains the preliminary results, that is the main recommendation, one for each stakeholders. The second version is an academic paper that presents the 5 highest ranked recommendations with concrete suggestions for implementation. The additional 8 recommendations for the remaining stakeholders group are presented as second-line interventions. Please note that the paper has been contemporarily published in English and Spanish by the Journal of Palliative Medicine, and that translation to other languages are expected soon. The first line recommendations are to policymakers, academia, university and colleges, healthcare workers, hospitals and healthcare centers, palliative care associations. The recommendation to policymakers. Policymakers must recognize the societal and ethical value of palliative care and modify the existing healthcare structures, policies, and outcome measures to ensure universal access to palliative care for all patients in need. They must also take the steps to ensure an integrated health system, to allow a smooth flow of patients between the different levels of care, so that patients with complex problems may be referred to secondary and tertiary levels as needed and referred back to home care if possible. Recommendation to the academia. All academic institutions offering degrees in healthcare-related fields should include mandatory palliative care courses as part of the undergraduate curriculum. Healthcare professionals working in palliative care should receive appropriate certification while actively participating in continuing education to maintain the adequate competency levels. I missed one paper. Okay. Recommendation to hospitals and healthcare centers. Every hospital and healthcare center should ensure affordable access to palliative care medicine, included in the WHO model list of essential medicine, particularly to immediate release oral morphine. It also should accept palliative care provision as a moral and ethical imperative. Representatives of national associations should be advocates and work with their governments in the process of implementing international policy framework, including convention resolutions and declarations in their countries. For these 5 recommendations that we have read, the group provided also the first steps for implementation. The second line recommendations are to international organizations, mass media, philanthropic organizations and charities, pharmaceutical authorities, patients and patients group, spiritual care professionals, associations other than palliative care, pharmacists. The recommendation to international organizations. International organizations should encourage WHO member states to develop policies and procedures to implement the WHO resolution as an integral part of their strategies and to implement the Agenda 2030 for Sustainable Development Goals, paying specific attention to the needs of children and older persons. To the mass media should be involved in creating a culture of understanding around advanced illness and the role of palliative care throughout the life course and as a component of universal health coverage. to philanthropic organizations and charity, individuals and organizations involved in palliative care must engage, educate, and advocate for philanthropic organizations and charity to support palliative care development and implementation of services. To pharmaceutical authorities, morphine, immediate release oral formulation, is the preferred medication for the treatment of moderate severe cancer pain and palliative care, and should be made available and accessible. No government should approve modified release morphine, transdermal fentanyl patches, or slow-release oxycodone without also guaranteeing widely available immediate-release oral morphine. To patients and patient group, patients and patient groups could be of great help in developing and demanding a health literacy campaign for all patients with palliative care needs and their families to increase the knowledge and understanding of palliative care and its role in the decision-making process. Religious institutions and spiritual care groups should work to include spiritual care integrated into guidelines of care and as a component of routine palliative care provisions. No palliative care professionals, associations, and societies should encourage human rights organizations to consider existing declarations and to implement strategies whose aim is advancing palliative care development worldwide within a human rights framework. Finally, the recommendation to pharmacists should play an active role in palliative care teams by assessing the appropriateness of the medicine prescribed to patients, by ensuring timely dispensation, by educating the team members about pharmacological interactions, and by ensuring that patients and caregivers understand the prescribed regime to ensure adherence to treatment. All the results are now collected in the third version of this research of the study, and this is the third version that we call White Book for Global Palliative Care Advocacy, because it contains all the additional recommendations discussed by the group, but not ranked within the highest scores. The White Book is being published and will be presented officially at the next Pontifical Academy for Life's General Assembly at the end of February. I wish to note that the white paper and all their recommendations have been elaborated by an independent group of research, that the results have been endorsed by the Pontifical Academy for Life. And in the White Book, the Academy wanted to share a special message that is contained in the epilogue of this book. And this message is about the close relationship between religions and palliative care. In the epilogue, we can read that the dignity of the human person, the sanctity of life, a caring attitude toward the most vulnerable, and a mutual social responsibility in reaching personal human fulfillment are key concepts of all religions and are core values of palliative care. Only a rationality open to the sacred makes it possible to affirm that there is an intangible preciousness in human life, even when it is fragile and apparently defeated by illness. Palliative care embodies a vision of the human being who is profoundly religious, and precisely this vision is the true soul and the true force of palliative care. At the end of this presentation, I wish to inform you about a joint declaration on end of life and palliative care by the Methodist Church and the Pontifical Academy for Life, similar to that signed yesterday by Ms. Sultan Afdal and Monsignor Paglia. And the strong conclusion that we would like to reaffirm, and that has been also a strong reason to create this project, is that palliative care is a privileged context to rediscover the life of the human spirit and religions in contemporary medicine and society. So we recognize in palliative care not only a valid clinical model for end-of-life care, but also a strong social and cultural power. You can find more information and follow all the updates on the PAL Life project on the new website of the Pontifical Academy for Life. Okay. Thank you for your attention.
Well, you might wonder why somebody from education is here. Well, I have another hat, which is ethics, so that's why I am here. Let me first thanks Georgetown's and Dr. Ahmed for asking me to be involved in this important sessions. This is very important for, as you said, globally, but it's very important also for us in Qatar. I will speak first a little bit about Qatar. I know that Dr. Azza, inshallah, will add more that in being a Muslim in Qatar and a lot of Qatar, elderly and old people represents something very important to all families. We have what we call the big families in Qatar, where the whole family, they try to be together. In the past, when we hadn't had that much financially, we were living in one house. Today is in one land where you have several houses close to each other because we are in a better financial fit. But it's very important that we always visit each other, make sure that each one are there. And there is one duty that we have to do. In Ramadan, the first thing, Ramadan is the fasting month. The first thing we have to do is we have to go to visit all elderlies and make sure they are in good health and all this. In Eid, we always start to visit the elderly and then we go to other houses to congratulation for Eid. So there is a lot of care that is taken inside us. And whenever any one of them is in hospital, I would advise you just visit one time to the hospital to see how many peoples are around that person when he get sick there, because the social is very important. I'm not saying we are perfect. There might be some exceptions, but I'm speaking about the majority in Qatar that's happening like this. In addition to this, the government has also taken a lot of things that related to palliative cares. Today, we have nurses that visit the elderly in our houses to take care. I had my father, when I was my father, they were all the time visiting and taking care of them. We receive the food like milk, everything from the governments, free of charge for Qatari and with minimal payments for non-Qatari who live in Qatar. All things. even diapers, all these things the government provide us free of charge, so makes our life much easier. And also we have a hot number to call whenever there is. So these things provide a lot of things. But going back to the paper, the white paper that I don't know how long I have, if you allow me time. I think this white papers, it's a milestone in palliative care. It's a very important step for us and for the world to go ahead with something that has been probably ignored in the medical field or hasn't got that priority, let me put it, in the past. When I looked at the recommendation of the paper and this, I think, the experts, they come with, they almost covered all the recommendation that has been, that could be covered. Though I thought that priority, I would have, put the healthcare and the, health professionals and the hospital prior to education, because I think healthcare and these things, this is something immediate, while education is something that you build on long run. So it's better to work something that will be tomorrow than something we will gain after a period. So I would say, first is, the governments are like this, then, the hospital are like this, and this. And that's why the voting even, they are very close when you look at the voting regarding these points. I think this needs to be done globally more. We have to look at this in several research in, everywhere in the world, because, this is the efforts of 13 experts, but I think if we expand the expert to a larger number, we will have much more feedback. I was just discussing with Dr. Pablo, I always work with him in research. He's from Cornell in ethics, and telling him, let's take it from here in Qatar, to do some kind of research about it and about implementation in Qatar and how can we follow up. We've done one about disability earlier. We had a grant about it, and I think now it's time to take it from here. That's briefly about what happened in Qatar, but I was attending today's morning. I couldn't attend, but I was attending the meeting, and I must tell you also that being in the Cancer Society, we are one of the charity that allow to collect the donations, and most of that donation is used to pay for cancer patient medications, which is very, very expensive, not for Qatari, for non-Qatari. And there are people who travel to Qatar just to get that and go back, So because of that, we put a little bit of limitation. So that's not used. We're trying to help the people who are inside Qatar, but human is a human. We try to help those come with certain limitations. I must end up with the personal touch, if you allow me and time is allowed, is that, I went through the experience, as others said yesterday. I was in New York attending meetings, and I had a phone call that my father, who's 92 years old at that time, is in intensive care. So, I took the first flight, I came back to here, and, I saw all the family around, and you can't believe it. My neighbor, they acted even, to help him and everything. So that's what I said when everybody works like this. So in a while, then he said they have to put him in a ventilator, and, I have to sign the consent for him. I'm the only child, by the way. No brothers, no sister. Good and bad. Yeah. I signed it because I saw my father, in desperate need, and I might lost him. And he hadn't had that much problem, except he's getting old. Yeah. So I allowed them. They put the ventilator in. Second day, he is good. He come back. He's breathing normal. It was a breathing problem. Why he was this problem. Then I saw a doctor there, and he took me to the corner, Qatari doctor, and he told me, Dr. Khalid, you should not, I wish you didn't do that. Don't harm your father. Yeah, much. I said, I can't. I am seeing my father in need to say no for that things like this. But what he said, I mean, it started to ring a bell in my mind. What happened is that after a few days, he had a stroke, and they have to do recitation for him and like this, and I have to sign a paper that there could be rib fractures and all these things, and that's where I went back to this. I said, I think it's time for him to say. So I went through both action, where one time I thought it's very important, and one time I thought, I think, the God. To conclude, I'm saying we also have a faith that God plans things all the time for us. I personally always think that, we know a lot, and we have a standard in medical practice to do, and when is to do, DNR or anything else, But there are a lot of things that we don't know in medicine and others. That's why we're doing research, okay? I keep saying, I'm a geneticist. I keep saying the people, 20, 25 years, we are saying DNA is a nucleus. That's the DNA. Today we know that there is mitochondrial DNA, and we have disease in the mitochondrial DNA. So does that mean mitochondrial DNA was not available 20 years or 25? No, it was there, but our knowledge didn't reach it. So the same thing, I think that in human, there are, maybe people are different, they're immune. There are things that we as scientists, we did not reach. Therefore, it's the right of a human to decide, yes, I want to continue, my life, because I can believe in miracle, I can believe in a lot of things. Thank you very much.
Thank you for inviting me to share with you the experience of palliative care. I should comment on the paper. It's an excellent paper for those who need to have like a guideline or recommendation how to start the palliative care from zero or non-existent palliative care. So you tackle all the recommendation from stakeholders, from healthcare, from specialty. But I wanted to comment about the most three important pillar. Like when we trained in the palliative care, when you wanted to start a palliative care program from zero square, so you should have three important pillars. The first one is policymaker or governmental policy, and the second one, expert in the field of the palliative care, specialized palliative care, and the third one, the drug availability. I think is the three main pillars are the three. Without one of them, you cannot start the palliative care. Because when we started the palliative care here in Qatar, we started by policymaker. The policymaker recognized that palliative care is very important to complete the health of any person that they need palliative care. And then they started to search for the specialized team to start the program. And the specialty started to the career from nothing, but with a drug, like one or two drug only, we started to expand and ask for more medication to be available here in Qatar. So with the broad mind policymaker and also with the specialized team, we started to have excellent program for the oncology patient. And right now we have like a dedicated unit in the cancer center dealing with adult oncology patient. We have 10 dedicated beds. We have most of the medication, necessary medication available here. We have consultation service that looking for the patient not at the end of life, but also early integrated in the journey of the disease from the beginning. And we have also care at home, but it's still has some deficiency because we are not looking by ourselves as a palliative team to go home, but we have like another nursing staff going helping us. And the national strategy of Qatar helped a lot. In 2011, they started to put the palliative care on top priority of their recommendation. So we moved a lot and we progressed a lot since 2011 up to 2016. And right now, the program of palliative care was only for the oncology. But in the new strategy of Qatar that started since 2018 up to 2022, they implement a healthy life for geriatric as well as end of life also for patient. So here they are looking to non-malignant condition also. But it's a very important. Every recommendation is very important and very essential. But we cannot say we don't start by all these recommendations. We cannot start by. We can start with the minimum.
Yes, some further comment to explain that. Of course, it could appear strange that pontifical institutions start a so scientific technical project. Indeed, the Pontifical Academy for Life is not a healthcare facility, has no health task, has a cultural task, societal, cultural, educational task, as we have said at the beginning of presentation. So initially we created this group of experts. Really, we searched for the most relevant experts in palliative care advocacy in the world. But at the beginning, we didn't know what would have been the result of this first meeting, where we were just looking for some advice to promote palliative care culture. Because, many regions, many places in the world are facing serious cultural problems about end-of-life care. There are different solutions proposed: medical assisted suicide, euthanasia, or palliative care, or abandonment of the patient. There are several practical possibilities for advanced or terminal patients. So our priority was a cultural priority to promote a culture of caring and accompaniment for the patient. And in the palliative care model, we also saw a cultural proposal, not only a practical, technical approach to end-of-life distress, symptom management, and so on. And so it was surprising for us to have this result that is a white paper, but with awareness that the work has not finished, has just started, because we have very general recommendations that come from the expertise of researchers taking different experiences, because they come from different regions of the world, different cultural backgrounds. But this is the minimum common to all the palliative care experts, researchers in the world. But the first step, absolutely necessary, because this work is incomplete, is to elaborate steps for the implementation. And this requires a local, regional work. This is the starting point. I think valid everywhere, but not ultimated, not completed. Now we have to continue, but the work necessarily has to be regionally, locally, to address practical issues, to address the reality of a person that have a name and a surname. They are very concrete.
I just wanted to hear a little bit more about what position you think the PAL Life White Paper occupies in relation to other kinds of national and international statements. What's different about it? What's the same? Where does it stand in relation to WHO statements, national statements from other countries, etc.?
Okay. Okay, this is a good question because the white paper perhaps doesn't say anything new. Maybe the contents of the white paper, the recommendations, are already contained in present in other international recommendations, regulations, and but I think that the novelty can be in the source that is offering this kind of recommendations. Yesterday, I think, or during this workshop, we have said that healthcare, Catholic healthcare facility provide caring for many people, especially in low-income countries. But I think everywhere in the world, also in countries where Christians or Catholics are a minority. So it was important, the first goal for us, to encourage, to foster with a pretty authoritative document for this target, to foster encourage commitment and attention toward palliative care development. But we were said that that the Catholic Church or the Catholic reflections is authoritative also for other people on the ethical issues. So they were strongly encouraged to produce a new document coming from the academy in order to sensitize people that could have been taken seriously the proposal of the academy.
Yes, yeah. I think, the white paper has presented important things, as I said, but the most important thing is what you mentioned is where we are going from there. I think its implementation is very important. Now this can set up certain guidelines for countries that want, but it has to be implemented. I was involved with human rights, cloning, genome. We took it stepwise till we take it to the United Nations, as a resolution in the United Nations for these things. I think it's very important at certain levels that we reach some of the high organizations such as WHO or IBC, which is International Bioethics Committee in the UNESCO, to start to put, they work in important, this one. It takes time, probably 5, 10 years, but at the end we get some kind of universal resolution regarding this, because there are even, there might be some modification in the documents about the human right to correlate. It was, someone talked about it, yesterday when we were speaking about the legal aspects. I think it's the implementation very important. A lot of time when we bring something, it's very important that there is a group, they follow implementation short, and then revise it in 5 years to see what happened, and like this to see if it was effective in that way. Thank you.
Priority number 1 is mandatory palliative care. Your first priority was mandatory palliative care courses. What would the curriculum look like? And how would it be structured? And how would it be structured in different places? Did you give some thought to this?
Not specifically on this topic, because, for example, there's work has been done in excellent manner by Palliative Care Association. For example, there is the International Association for Hospice and Palliative Care that provides this kind of tools that we consider absolutely valid and good tools for education training and for implement these recommendations.
I can comment also on the education. In my opinion, also education and training, we can divide for palliative care into subgroup. We can start by level 1 or basic, which is mandatory to be in the medical school, in the nursing school, in all the undergraduate for healthcare providers that will be graduated and serve in the healthcare, like social worker, like dietitian, physiotherapist. They should be aware about what is the meaning of the palliative care, what is the principle, and just a few orientation and recognition from their curriculum about what is the palliative care. Because we found that medical doctor, when we start palliative care, they don't know about what is the meaning of palliative care. Even the nurses, we did like a survey about when I started the palliative care in 2008, about what do you know about the palliative care, pain control, opioid. The ignorance regarding the palliative care was massive as the starting of any palliative care program. So basic education is a must and obligatory in for healthcare provider. And after that, intermediate level of education for any healthcare provider dealing with terminal or end-of-life care patients, like for cardiology, for cancer patient, they should know how to deal with the end-of-life and dying patient. And for specialized palliative care, we should have like curriculum, like fellowship program and training to graduate specialized physicians, specialized nurses, specialized social worker, spiritual advisor trained in palliative care, in specialty of palliative care.
I will add a small thing also. I think also when we meant education, and correct me if I'm wrong, we meant also basic education. We have to reach basic education to raise awareness between the children and raise awareness among the people, publics. It's very important that's integrated in the education in a simple way so that they know this one. Thank you.
I think particular to the discussions we've had over the last couple of days, that this is an aspect of promoting medical care which includes religious influence. Most of my interaction with medical field rejects religious influence. And I think that what we have been discussing the last couple of days and the WISH report that came out is really fundamental and important to the medical profession in providing the fundamental concepts and values of where religion fits into palliative care, because otherwise there are many, many people going to reject that part, which we have been discussing, because there's this dichotomy in the world of science and the world of religion, and never the two shall mix kind of problem. And because of that presuppositional discrepancy, there's great hope in this process for promoting a holistic medical approach to palliative care, because it includes everything, the family, not just the patient and the doctor. So I think there's great hope here, but where do we go? How do we make it work?
Yes. The group reached a consensus on these recommendations. That is about the relevant stakeholders, and the stakeholders includes also spiritual or pastoral workers and religious faith or associations. And as I said, maybe recommendations represent a minimum that is common to all people, that because they recognize in the essence of palliative care. Perhaps we have described the essence of palliative care as a medical and human enterprise. And of course, we know that as all the fields of medicine require an attention to the particular patient. And we have to take into account this particularity and of caring. That is, I think that this requires more work and steps on to reach this kind of answers in a practical way, to have a true implementation of palliative care for each patient.
Just on that last comment and point, and if the goal is to increase, if you will, the legitimacy and appeal of this white paper to a wider audience, especially from different religious groups or faith communities, do you plan to reach out to some religious organizations, for example, to try to reach some sort of agreement or some sort of common understanding also, through which the followers of these, religious institutions, of course, would see that this, through that agreement, the document is, as you said before, is more authoritative or is credible, if you will, at least from their perspective. So in the Muslim world, for example, do you plan also to reach out to some religious organizations or representatives of some, of that sort, or that was just a, question?
Okay, we are trying to do that. I think that we are in a very initial phase of this work. The paper has been just published, and it has been, this result has been a surprise for us. As I said, initially we didn't think that this group could produce okay, they can produce a high-level scientific work, but that their work made for the academy that could have been this important welcome by the academic and scientific community in a scientific journal. So we are still planning, and we ask largely for advice how to implement and reach and what the paper recommends. We are working through the Palliative expert group. For example, Christina Puchalski, that is a leader in spirituality and medicine, is helping us to stay in contact with chaplains associations in the United States, in Europe. We have, for example, Raja Gopal in India that supported and promoted the program of the Catholic Health Association of India that endorsed the white paper, and now with Dr. Rajagopal, that is the president of Pallium India, the Scientific Palliative Care Association of India, they draft a program to have a presence of basic palliative care in all Catholic healthcare facilities in India. So they started a program, a gradual program. I suppose it will take a long time, but it has already started a program to train nurses and physicians in palliative care and make that each Catholic healthcare facility in India can have a palliative care nurse or physician. At the moment, these are the practical results that we have reached. But I think that the white paper and the Palliative project especially has to be intended as a proposal launched by the Pontifical Academy for Life to the Catholic world, okay, but to everybody, and to strengthen this kind of relationship. Maybe Pontifical Academy for Life would appreciate a cooperation with other religions, also due to the role that recognize to the religions in palliative care. We think that working all together, we can reach these medical but also cultural and societal results that we need today in end-of-life care, but more in general in humanity and solidarity. That is the ultimate end that we have with this project.
To go back to the question that was raised earlier, is the issue here advocacy of the role of religion in palliative care or advocacy of palliative care, regardless of whether one is motivated by secular ethics or religious ethics? This is a significant question. I don't think we can, I think it needs to be addressed head on, you know, ultimately so.
Because it's global. It's global.
Ultimately is, I think, is to advocate for palliative care, because palliative care is an ethical model that I think we can appreciate, and we don't have necessarily to add something else to the model of palliative care. But we recognize that also there is there is the possibility to reinforce these ethics with religions. I think that we should not consider palliative care field in a different way from other human fields. Medicine and other fields of human actions, human life, can have a good natural ethical dimension that we have to appreciate, we have to recognize. But personal opinion, religions is not a totally optional or indifferent, irrelevant dimension for the life of the human being, for our existence. So, end of life has to do with so profound existential issues that we cannot deny no palliative care expert, a physician, professional denies that spiritual dimensions is relevant. You can decline this spiritual dimension according to a religious faith or different religious faiths. But I think that religions, however they differ in their institutional forms, are common in nurturing and sustain the most deepest needs of the human being, and is a transcendent dimension.
I just want to, your response to the question that was posed and the pushing that Professor Dalal was doing, I want to make clear maybe an assumption that maybe you all have, but I don't as a minority faith in the context of the United States, Muslim. Perhaps you don't have the same hang-ups that we do. But I always feel that we are responding to a society that has moved beyond religion. That medicine has been instituted globally as a practice that has some, we cannot deny there's spiritual dimensions of health, that there are religious aspects of health become important to individuals, some individuals, but it is not one that is started off, originated at this time as a religious enterprise. And you have Catholic healthcare systems, so maybe that's different for you. But I have that hang up, so we're always responding. And when we talk about, so when you said the statement that we are for palliative care, but the definition and the framing of palliative care is not one that was started off by the Holy See, nor was it by Al-Azhar. It has been instituted by a movement that's outside of it, and we're trying to offer perspectives, or I thought the last 2 days, of how we can incorporate value systems from these traditions to make it and reform it, or re-envision it, or reinvigorate it in a certain way. So I'm kind of taken aback by if you think, by your statement, and I'm trying to understand, maybe it's because I have a hang-up as a Muslim minority in the States, that you don't see that we're outside of the scope. Perhaps, so can you just explain that? Because I think we're responding.
Maybe.
I have a similar comment, but a slight variation. I think that even the contemporary palliative care movement did begin with, I think, religious inspiration. And that's undeniable historically, but it is quickly being forgotten. And I think that part of what I see as the thrust of this is to maintain the purity of what palliative care is, because it is in danger, at least in North America, of becoming instrumental in the same way that other kinds of medicine become. It's sort of consumer options, preference satisfaction, using medical technology in ways that are in ultimately dehumanizing, and further, there is intense pressure in the Benelux countries and in Canada, and increasingly, presumably, in other countries where assisted suicide and euthanasia are legalized, to make those practices mainstream to the practice of palliative care. And I think that the message that's being given by you and by some of the previous statements about palliative care, its goals, et cetera, are maintaining a focus that is not where a lot of palliative care is actually now going internally as it becomes an academic medical practice.
I just want to echo that. Actually, one issue is that we have made this discussion so intellectual that we forgot about actually the family and the patient to an extent. I know that's what we are trying to address, but to what extent the family's views have been incorporated into recommendations and policy, to what extent their issues or their experience have been expounded on in such a way that it reflects what we are trying to accomplish. I think I've seen this in the past where this becomes so much intellectually driven that you forget the emotions behind it.
Just to follow even further, I think that what we've been talking about today, if it can be extended on a much broader scale, would empower the average patient and family to insist that they must have spiritual care. Because when they're in a medical context, it's almost like you must leave your spirituality behind. And I would just make a simple proposal that this process is referred to Al-Azhar for the Islamic world and to the World Council of Churches to affirm, support, publicize, and implement educational programs, both within the medical field and within the religious establishments. It's a proposal.
If indeed this is the case, then we cannot, the way we addressed the initial question of the mandatory palliative care courses, we cannot say we'll defer to the institutions. If we have to think about the content of the educational curricula that we're proposing and advocating. Sorry.
Several questions. So I spent time with palliative care teams, and I have learned a lot by them. And I am convinced after this experience that palliative care team, palliative care situations, that is including team, patients, family, can be a place to start to learn again humanism, dignity, solidarity, ethical values. And I'm saying this not in a theoretical way, having read it in any book, but starting from my lived experience with them. So if we intend to teach our culture what is dignity, what is respect for the dignity, what is caring each other, we can find a good example in palliative care situations. I think that is a shared experience among us, maybe especially in Western culture countries, that sometimes patients or family comes being strongly supporters of euthanasia or asking euthanasia, but usually the patient-physician relationship is able to convert, to make change this idea, and to value palliative care approach. This is an approach. So I think that this is the response that we should do to the society, to the contemporary culture about human issues, human aspects that are also considered or a topic for religions, but they are not out of the life of the people. So, looking at palliative care situation in a hospital, maybe in the hospital of Azza, I think that we can encounter this core of value that is what precisely our culture and society needs. Societies more oriented towards utilitarianism, discriminations, selections. This is a language that palliative care don't know. Palliative care don't understand the language of utility, of discrimination, of selection. And they don't practice anything of that. They know the language of accompaniment or comprehension or welcome or understanding, of respect. They live, they practice that. As they practice that, they become an example, witness of such profoundly human values. And you can have circles, starting from the patient, continues to the family, that they go out and understand what is the right, the appropriate care at the end of life. I think that this is the response, very practical, and also the goal of this project, the support that we give so strongly to palliative care.
This appeal to education as well as religious bodies will continue for some time.
We hope so.
That we're only really in the beginning. This is only your second conference since your plenary when you launched this, so that we're just in the infancy of the project, are we?
Okay, it is not up to me, but...
Well, you're in authority here. I don't think Father Ciucci would mind. You go ahead. And the Archbishop is gone, so...
But anyway, we strongly hope to see a result. First result is that it's like a dream now. There's no one has to ask for dying because of pain, physical or spiritual distress. How to reach this result, we ask all the palliative care community in the world to help, to understand how to reach this practical result. We are interested in persons, and we will be satisfied when the white paper, only when the white paper will be translated in well-being or decreasing suffering or concrete accompaniment and peaceful death, I would say for all people that are in need. I know that it is not possible, but yet to reach concrete people at the end of life.
Hi there. I just had a question about the local context here for those of us that are working and are seeing patients and families every day that are, dealing with death and dying. What can we do you think, here locally in Qatar to move things forward and make change in a practical way? Is there a space where we can continue our dialogue from today as a working group to come together from different institutions? Just even meeting you today was so helpful for us just to make that connection with you guys at Hamad. So I'm just wondering, what are the next steps practically? What are the challenges here locally in Qatar, and what are the next steps we can do practically to support families here?
Yeah, I'll speak and you can continue. I think, there are important things that we can do. And, I saw you signing, WISH is one of the places that is, they must have a major role in this one. Ministry of Health and, other health institute will have a role on this. But as I said, it has to be followed up, like this, yeah. I can't think of real, association beyond the governmental association that's very effective in Qatar to approach also. Okay, the only one is the family, that we have the family, associations, which is, is more keen toward the children and to their women's right and like this. Therefore, I think it has to go from there. At personal level, for example, I told you that from this time, I'm planning to do some research on this because, I find that, the land is green for me to start some kind of work in Qatar for this one. I have to look which angle I have to go in this one, and I have to get the budget and everything for this. But that's what I think. We have to go through several like this in meeting. I think PD sessions in different institutes, especially in medical, is very important. The PD session, professional developments in, in the hospitals, in healthcare, and all these places are very important. And finally, we have to get some kind of, awareness seminars for the publics and like this. The most effective way to do whenever you go for awareness and this is to real example, to give real example where people can be, we do this with cancer, where we bring the cancer patients, we have the cancer children there in the cancer society, for example, in Qatar, like this. I think we can take it. That's very important questions. It should not end up with the sessions in Qatar. We have to take it, and I would put the ball in WISH.
Thank you. I think when we started this conversation a couple of days ago, we did say that, our report is a foundation for discourse, and we're really interested in working with key stakeholders within the country to put that conversation forward, to build that type of awareness. And I think workshops, awareness campaigns, actually defining what palliative care means to us with such a multi-faith society is really important. And encouraging Hamad Medical Corporation. I think that Meha would know this better than me, but I think looking at what we have and how to assess what we need is possibly the first thing that we want to do together. Because we can't, as much as we study the topic, for healthcare providers within the hospital, we really need those stories, as you said, and also the experiences of the healthcare professionals. That's gone a long way for us to defining that palliative care was even a topic that we wanted to discuss because of the healthcare professionals. Because it wasn't even so much the stories or the personal stories. I think it was the healthcare professionals' own bafflement at where they are and where they're supposed to go and where the law and healthcare guidelines allow them to go. So I think that, definitely it's a conversation we want to expand on, and this is hopefully just the beginning.
I have also one comment or one suggestion. In your hospital or in your place of work, you have you will find your resources. You are a social worker, so you are a specialized social worker. You have a clinical nurse specialist. You have bereavement counselor. So this is your resources. You have primary care physician. You can find who is interested in the palliative vision. And also you can get experience from the models that we have here in Qatar in the oncology. You can contact us at any time. We can visit you. You can give opinion. So you can grow from this. You should start whatever your team is small, and then you will grow very quickly, inshallah.